Hello, I am Dr. Shailaja Kale. I am a diabetologist from Pune, India. I spoke on the topic insulin treatment in pregnancy in this meeting. So, I will be briefing about insulin treatment and some important aspects why we should keep the glucose under control in pregnancy. We know in India or South Asian population, this ethnic population, the rates of diabetes are very high. We know that background type 2 diabetes is increasing, and that is reflecting in lots of girls having diabetes during pregnancy. It's known as gestational diabetes, but there are also girls who actually have diabetes before pregnancy but gets diagnosed during pregnancy because it is tested. And plus in pregnancy, the insulin activity decreases because of pregnancy, and the insulin sensitivity goes down and resistance increases many fold. If the girl's pancreas, the mother's pancreas are not capable of handling this high insulin resistance of pregnancy, then the glucose goes up and it gets diagnosed as hyperglycemia or diabetes during pregnancy. So, this pregnancy and diabetes is very common in our population. It's not only happens in obese girls, it happens in even thin girls. It's not only in urban, but it is also there in rural. Elderly girls, 30-32, it is very commonly seen, but even in young girls nowadays it is seen because we know there is lots of diabetes in our population. Now, this high glucose in pregnancy, I will like to mention here mother's pre-pregnant weight. So, the obese girls, the obesity as well as high glucose has lot of deleterious effect on the baby and in the pregnancy. So, baby's fat mass is decided by mother's glucose and some other important metabolic factors. If higher the glucose, more is baby's fat mass, which is decided by abdominal circumference during ultrasonography. The baby's fat mass actually decides baby's function of kidneys and the pancreas and the beta cells. So, the babies which are born with more fat become more obese in their pubertal age, and they get more diabetes when these babies become young adults. So, we are increasing the diabetes in the population if the mother's glucose remains untreated. Higher the postprandial glucose, more is baby's fat mass. So, 1 hour glucose or 2 hour glucose, more is the peak, more is baby's fat mass. That is a strong correlation. Along with that, there are certain like mother's triglycerides, amino acids, all these factors decide baby's fat mass. There are certain factors which decide fat free mass in the baby, which is 12 to 15% at birth, like mother's height, sex and the genetic factors which are decide. But the fat mass is important as a metabolic problem which decides future diseases like diabetes, hypertension, heart disease in the population. So, those who are born thin but more fat, in the adulthood they get these diseases. The cornerstone of treatment of this glucose in pregnancy is insulin. We do use metformin, but we do not use oral drugs because they cross placenta, except glyburide in a very rare situations after second trimester, but the main treatment in pregnancy remains insulin. There are criteria, there are targets which we can get from different guidelines, but the fasting has to be below 90, 1 hour has to be below 140 and 2 hour has to be below 120. In a Asian Indian population, usually the peak of after the food is at 90 minutes, so about 1.5 hours. We do lots of testing in pregnancy, like they check their glucoses at home and keep the charts maybe every day, 4 or 5 times in a day whenever they eat. Then you can decide insulin doses. We do continuous glucose monitoring to see how the glucoses are behaving and decide the insulin doses. Multiple insulin injections, small doses, and maybe one basal insulin is the main thing which has to be used. It has to be followed up by seeing how much that girl is gaining weight in pregnancy, how is her sonography behaving, what is the Likert amount, what is the baby's abdominal circumference, and also the continuous glucose monitoring. And according to all these parameters, we decide how much should be it should be treated with insulin, what should be the dose. And that's how you can manage this hyperglycemia of pregnancy. We know only about glucose because there is a HAPO study which correlated mother's fasting glucose, 1 hour glucose, 2 hours glucose with the baby's weight and baby's fetal insulin levels. So even fasting glucose is very important, it should not go beyond 90. So after metformin, diet plays a very important role. Many times just changing the diet controls the glucose. If the pregnant girl eats poha, which is a very typical Indian breakfast, the glucose will be 200. If she eats eggs, it will be 120. There is so much of difference with what food we eat. So giving a good nutrition by decreasing carbohydrates also a very important factor when we treat these girls. All insulins are usually the aspart, natural human insulins or Lispro, these are allowed in pregnancy. Among the basal, NPH and Detamir are tested and they are category B drugs for the insulin. So that's what in a brief, if you have glucose under control, there is one word of caution. If we treat too much of glucose, like if you keep it too low in pregnancy, baby's size goes down. So lot of things you need to look when you are treating with insulins: mother's glucose, mother's weight gain, how the baby's growth is happening between the two sonographies, how much is the Liker amount, and then treat judiciously, and we can treat with kind of a basal bolus treatment. A1C measurements can also be done. Around 6% is the target. So if at the third trimester it is around 6%, the outcome is much better. So that was about insulin treatment in pregnancy, and I come from Pune, so we treat lots. I think across India there is a lot of diabetes and pregnancy, and everyone should be aware about these facts. Thank you so much.